Hello and welcome to the health program on Trust Television. I am Aisha, Salihu. On the previous episode of the program, we took a deep dive into blood infections and disorders. But this week on the program, we'll do a follow-up on the conversation. It's important to note that blood disorders encompass a variety of conditions that affects the components of blood, including red blood cells, white blood cells, platelets, plasma, and the mechanisms of coagulation. These disorders can lead to significant health issues ranging from mild to life-threatening issues, according to experts. Understanding these conditions, their causes, symptoms, and available treatments is crucial for effective management and improving patients' outcomes. To give us those insights, we have joining us again Dr. Ugochi Adai, who is a hematologist. Thank you so much for making the time, Doctor.
Good afternoon.
And I'd like for us to pick up from our last conversation where we had talked about anemia, we looked at hemophilia, leukemia, among others. And last week we were just talking about leukemia, where we looked at the causes, the symptoms. I'd like for you to pick up from where we left off. We're talking about the symptoms and also the causes of leukemia and also treatment options.
Okay, to do a simple recap from last week, I made mention that leukemia encompasses cancers, basically cancers of the blood, and to narrow it down, mostly cancers of the white blood cells. However, there are times when you could have it as it could spill over to cancers of the platelet and even the red blood cells. We also classify them into the acute and the chronic, and we also mentioned that it could be the myeloid lineage of the white blood cells, and it could also affect the lymphoid lineage of the white blood cells. So basically, symptoms depend on what leukemia, but you have the general symptoms and then you narrow it down to the specific symptoms. General symptoms will entail symptoms that are related to shortening of the blood and shortening of the blood cell lines. So patient might come down with shortness of blood due to anemia, come down with symptoms of pallor, that's paleness of the body, shortness of blood, difficulty in breathing, due to shortness of in platelets. Low levels of platelets might present with bleeding when patient brushes, easy bruisability. For no reason whatsoever, or even the blood not being able to clot when you have an injury, which is not normal. And then you could also have symptoms of what we call constitutional symptoms, where you have unexplained fever, prolonged cough, night sweats even when the weather is cold, bone pains, unspecific bone pains. These are what we call, and weight loss, unexplained weight loss. These are what we call constitutional symptoms. Then you could have specific symptoms related to the type of leukemia that the patient is manifesting. For example, for an acute lymphoid leukemia, which is basically called an ALL, the patient might start to develop swellings in the lymph nodes and areas. You could have neck swellings, you could have swellings in the inguinal area and the groin area. Patient might present with abdominal swellings with enlarged organs, the liver, the spleen. Patient might also present with skin manifestations. In an acute myeloid leukemia, patient might present with swelling of the gums. Patients also come down with swelling. That's when, in case of anemias anyway, the legs might be swollen. Though generally, that general feeling of unwell. So generally speaking, you could have your general symptoms, and then you could have the specific symptoms depending on what kind of leukemia.
Okay, let's have a quick look at treatment and treatment options and management options as well.
Okay, well, basically, once you have a cancer, it's anti-cancer regimens that are used for cancers. You have the traditional chemotherapy, like I said last week, and then we have the novel drugs, which what we call targeted therapy, where you have your monoclonal antibodies, you have the CAR-T, what we call CAR-T cell therapies, the gene therapies, and stem cell therapies as options for treatment of chemotherapy, of cancers or leukemias.
Okay, now let us look at hemophilia. I know last week we couldn't do much about hemophilia. Let us look at hemophilia, the causes, symptoms, and also treatment and management options.
Okay, now we're narrowing down to the clotting fact, that's the clotting aspect of the blood. Now we should remember that blood is in a liquid state, and that liquid state is comprised of the blood cells, which is the red you see, and then that white clear parts which you see when it's separated, which is called the plasma. Now that plasma contains what we call clotting factors. They work hand in hand with the platelets to ensure that when you cut yourself, you don't bleed out. When there's an injury, you don't bleed out. So they form what we call clots, blood clots. Now, hemophilia, to put it simply, it's the inability of the blood to clot, which is caused by the lack of some of these clotting factors. So we have hemophilia A, hemophilia B, and then in some cases hemophilia C as the common types of hemophilia around. The commonest you will find, which is the lack of the clotting factor 8, which is what we call hemophilia A, is the hemophilia A in environs. And of course, the lack of clotting factor 9, which is the hemophilia B. These are the commonest one, with A being the much more commonest one in the environment. It's worthy to note that hemophilia is an X-linked chromosomal abnormality, which simply means that it's the mother is the women or the girls are carriers of this deficiency, and the manifestations of hemophilia is seen mostly in males, the male population. However, there are some exceptions to females developing hemophilia, but let's not delve into that. So predominantly you will see it in males, and in children it could present as early as a childbirth, when during circumcision. So we usually could find out from them if you have a history of a child who got circumcised and kept bleeding, and kept bleeding without clotting, or when they start to crawl, when children start to crawl, they now develop what we call hematomas, which are blood collections on their knees from crawling. As they grow older, depending on the severity of the hemophilia, they could have different presentations. Some of them might not present until, that's the mild form, might not present until maybe patient has a serious issue, like maybe a serious road traffic accident or injury, or maybe during a surgery, and then you find out that you cannot control bleeding. But for the severe cases, they develop bleeding spontaneously. They could wake up one day and they are bleeding into their joints, and have swellings in their joints, swellings in their gums, and so maybe little cuts and scrapes that shouldn't be much of a problem might become a serious issue with them. And in very, very severe cases, patient might even develop bleeding into the brain.
Wow.
And so yes, it's the thing about hemophilia is that it varies in severity, just like I said. So you could have the mild form and then the moderate form, and you could have those severe forms.
So what then are the management techniques? Okay,
that's a good question. So being seen as it is defined as a lack of some clotting profile, it's worthy to know that you could now have those what we call factor replacements. So the purified form of these factors, in the olden days, it used to be that they would collect healthy plasma and refine it and purify it and give it. But now we're able to sit down and engineer it genetically. So you have those factors which are being replaced, and also in hemophilias, we also have targeted therapies.
Okay.
So you have monoclonal antibodies, that's what we call them. that are able to bypass this the genes responsible for this factor, clotting factor, and bypass the process and more or less bypass this factor deficiency and then complete the clotting cascade to enable the blood, to clot.
Okay. Now, I understand from majority of the blood disorders that we have talked about are mostly, I would like to put it that way, genetic disorders, which now brings me to the next point, which is thalassemia. What can you say about that?
Okay, we talked about sickle cell briefly last week, and
yes.
So you could call thalassemia as like the sister disease to sickle cell, because they are all classified as hemoglobinopathies.
Okay. Now,
whereby you have sickle cell being the replacement of a good amino acid with a bad amino acid. Thalassemias occur when you now have in the hemoglobin that is being replaced, you have a form of an incomplete hemoglobin.
Okay.
Hemoglobins are made up of what we call the alpha and the beta. And so when you have, you have 4 alphas, 2 betas. So in a thalassemia, rather than develop the 2 beta, 4 alpha to come together to form a complete hemoglobin, you could have the shortage. Let's call it a shortage of the alpha and the betas. So you could have maybe 1 alpha or 2 alphas and then a complete beta, and that's what we now classify that as an alpha thalassemia. Then or you have the shortage of the beta, and when you now end up with a beta thalassemia.
But then what would you say is the symptoms that this thalassemia presents with, and also the management techniques?
So the symptoms are akin and or close to or related to the symptoms you see with sickle cell anemia.
Okay.
So you have it depending on the severity of thalassemias. They can be classified as mild. You can have those severe forms. You can have the intermediate forms of the thalassemia. So sometimes in the mild ones, they may just go on to live a normal life, maybe showing up in their blood, only showing up in their blood films, or maybe their blood pictures when they do their test. But for the severe forms, just like you have in sickle cell, patient presents with symptoms related to shortage of blood. So patients present with symptoms of anemia and also abdominal distension, because the organs are trying to compensate for this anemia. So patients could present with a swollen spleen, swollen liver at times, and also they also find out that they also have that need to be transfused regularly.
I understand that majority of these disorders, we're looking at the management techniques, where you have stated that some of them are cancerous and others are not cancerous, and then we have chemotherapy, radiation therapy, targeted therapy, immunotherapy, stem cell transplants, even gene therapy. I'd like to hear from you, how accessible and affordable do you think these management techniques are for some of these blood disorders that we have stated?
Well, unfortunately, cancers are not cheap. In fact, most chronic illnesses are not cheap. Affordable, yes.
Okay.
Depending on the economic status. So yes, sometimes our hands are tied. You want to give the patient the best, and then sometimes these drugs cost so much. $10,000s, $5,000, especially the new drugs, the ones you talked about, the targeted therapy, the monoclonal antibodies, the immunotherapies, the CAR T-cell therapies, even the stem cell therapies. But yes, in our environment, we try as much as possible to mix, to come up with a regimen that could at least help the patient as much as possible. Some of them are even covered by the NHIS program. So
but then, do you think in Nigeria today, these management techniques and options, apart from affordability, do you think they are readily accessible? Do you think maybe perhaps majority of our health care institutions or healthcare centers are there, and then we can just go for people who are presenting with these symptoms and who have already been diagnosed? Do you think they are there and they are readily accessible?
Well, if I have to break it down into healthcare for them, I'll tell you that the manpower and as in the brain power to treat or manage these cancers are very accessible. But just like I emphasized, is availability of these drugs all boils down to the affordability of the drugs. So yes, you write out a regimen for a patient, and then the patient goes to cost it, especially the ones that are not covered, and finds out that, especially when they are paying out of pockets, and find out that it's within their reach or beyond their reach of the pocket. And the patient comes back, and then you have to sit down and revise the regimen to suit what the patient can afford, because once you start, the goal is at least to finish your cycles. And like I said, most chronic illnesses are not cheap. So we're not doing it's not like malaria that you treat once and for all and then you go. Most times we have to put the patients in cycles, sometimes up to 4 cycles, sometimes 6 cycles. Sometimes they have to do, and not just the induction, they have to also have the maintenance. Sometimes some of these chemias, we have to put them on maintenance for 2 years, 3 years.
Okay. Now, doctor, you'd agree with me that we can't talk about blood infection and disorders without at least talking about HIV and AIDS. What can you say in that regard?
Well, I think HIV and AIDS is a subject or a topic that has been flogged and overflogged over time. So at least everyone should have at least the basic knowledge of, what it is. So it's caused by virus, human immunodeficiency virus. It's an infective virus which is caused by transmission of bodily fluids, be it the blood, even the saliva, and other bodily fluids in the body. I would say that the prevalence, it's falling. The incidence, maybe not, but at least the prevalence, with the advent of drugs, with the advent of medications, they go ahead to live a healthy life. So you have HIV. The chief of mine used to joke that some HIV patients are more healthy than a normal person working, because they come for checkups. Once you take your drugs regularly, come for your checkups regularly. At a point, it becomes undetected. You live your life as much as healthy as possible.
Okay, now just before we let you go, I'd like to also hear from, I know earlier you talked about hemophilia, but this now brings me to bleeding disorders. I've heard about thrombosis amongst other bleeding disorders. What can you say regarding that? Causes, symptoms, and management techniques?
Okay, if you're talking about thrombosis, I assume you're referring to the venothromboembolic disease, which is a myriad which comprises of the deep vein thrombosis and then the pulmonary embolism. So where you have hemophilia caused by or lack of or absence of some of the clotting profiles, in thrombosis you have the direct opposite, where now the blood clotting cascade tends to clot much more faster or much more intensely than it should. So you now have an imbalance. In the other one is the lack of the clotting profile, and in this one is the ability of the blood clotting cascade not to be able to lyse that blood clot that is formed. Usually there's a balance between clotting and thrombolysis, what you call thrombolysis and thrombosis. And so when you have thrombosis, there's the blood clots, and then there's no inherent ability for the blood to remove this clot. And so going after a while, it forms like a blockade in the vessel, like a barricade in the vessel, which obstructs flow, and then leading to the formation of what we call a deep vein thrombosis. It presents with, if it happens in the leg or anywhere, it presents with swelling, presents with pain. Now, the complication of this is, if left untreated, it could end up as an embolus, which means it could detach from that vessel it's formed,
Okay.
and go to somewhere like the heart vessels and the lungs, the vessels of the lungs, that's the pulmonary veins, and then block that area, thereby causing inability to breathe, and most times, if you're not careful, resulting in death.
I was actually going to come to the presentations, I mean the parts of the body that it presents in, and also complications. I'm glad you have cleared that up for us. But then how do we look at, say, management techniques of thrombosis?
Okay, in managing thrombosis, the first thing you do when a patient comes is have a high index of suspicion, especially when the symptoms are there.
Right.
Unilateral, that's leg swelling in one or two of the legs, leg pain. If the patient has the predisposing factors to support this deep vein thrombosis, patient is at an advanced age, greater than 40, patient has a history of maybe smoking, patient has a history of a sedentary lifestyle, sitting in one place for a long time, or has gone for a long, has just undergone maybe a long journey recently. Patient is has been hospitalized for more than 3 days, has had a maybe POP on the leg, has had recent surgery, a recent stroke, anything that has immobilized the patient for a while. So given the history, or a recent fracture, with a POP, or has been hospitalized for a while, has been lying down for a while. So you put all these factors together, what we call is a triad, called a vicious triad. You identify any of the predisposing factors in this patient, and then you do what you call a well score. Is patient meets the criteria for that, the next step to do is to do a Doppler on that affected part. You pick up the thrombosis in that area. And then, just like you had in hemophilias, where you give replace clotting profile, in this one you have antithrombosis agents that you could give the patients, called the anticoagulants. So you start that, you give an external anticoagulant in order to, as much as possible, stop that process of the constant formation of the thrombus or the clot, and then by giving the clot that has formed time to resolve without adding further clots to it. So that's the line of management for treatment of thrombosis in the body.
Thank you so much. We have looked at blood clotting disorders where we talked about thrombosis. Now this brings me to bleeding disorders. We have seen some bleeding disorders in patients. Some present even when they're giving birth. Some it could be, especially in women, some it could be say their menstrual flow, the monthly menstrual flow. I'd just like for you to talk about bleeding disorders.
We've touched bleeding disorders actually. We started with the hemophilias, but another one worth mentioning is the von Willebrand's disease. In our environment, unlike the hemophilias which affect just males, this could affect both the males and the females. And just like you rightly said, females will present with heavy menstrual flow, and maybe during birth, heavy bleeding, postpartum bleeding, and that cannot be controlled. It's also a genetic disorder which is inherited, and it's passed on to the children. And just like the other ones, it could present in a mild form, it could present in a severe form. And just like hemophilias, we have replacement factors. You have tests to do to confirm that. Once the test shows that there's a high suspicion, patient has unexplained epistaxis, that's bleeding from the nose that doesn't stop after childhood, that just continues. Like you said, honest bleedings that stay, prolonged bleeding from bleeding puncture sites, and then bleeding from orifices, like you said, during the mental period or maybe during birth. Fortunately, there are also replacement factors that can be given for those bleeding disorders. Other bleeding disorders are the acquired ones, which we find in our environment. You could have, in patients who present with liver disease, could have a deficiency in vitamin K. Fortunately, there's vitamin K replacement for that also. Even patients who have chronic renal failure could present with bleeding disorders due to the high urea. So these are the common ones I could mention in our environment.
Okay, thank you so much. Now we have talked about blood infections and blood disorders, and in the previous episode, you talked about the use of antibiotics. I'd like for us to look at antibiotics as treatment measure for some of these infections. At what point would we say this has become disastrous? I mean, overuse or misuse of antibiotics?
Okay, there's something called antibiotic stewardship. Because you know that too much, in as much as everything is acceptable, too much of everything is never good. That also comes in the use of drugs. So misuse of antibiotics, it's there's always a prescription, there's always a directions for use, and there's always a doctor to direct you on how to use those drugs. So it's advocated that as much as possible, get your antibiotics prescription from a doctor. Use it according to how the doctor said to use it, and stop when the doctor says to stop as much as possible.
Okay, thank you so much. There we had Dr. Ugochi Adai. Thank you so much for making the time once again to share your expertise with us today on the program.
Thank you for having me.
Now, just before we go, I have an advice for you, our viewers there. Blood disorders present significant health challenges, but advances in medical research and technology offer promising solutions. Early diagnosis, personalized treatment plans, and ongoing research are essential to improve the quality of life for individuals affected by these conditions. Collaboration between healthcare providers, researchers, and patients is key to making strides in the prevention, treatment, and potential cure of blood disorders. And that concludes this week's episode of the program, Healthy Living on Trust Television. For comments, contributions, and suggestions, do well to follow and subscribe to all Trust TV social media handles. Download the Trust TV app on iOS and Android devices across their respective stores and get live updates on the YouTube live stream and the website. Join us next time as we continue to explore subjects crucial to your health and well-being. I am Aisha. Salihu. Thanks for your time.